Good morning, everyone. Thank you, Bombay Orthopedic Society and organizers for giving the opportunity. So we have seen so far the dorsal dislocation, which is a fairly common, you can see in day-to-day practice. But what is I'm talking about is the coronal and rotational. These are uncommon injuries, and you must know how this pathognomic happens so that we can understand about the treatment part as well. So here is one case about from the literature, 9-year male little had injury. Close reduction was attempted, but could not be done properly. As you can see in the X-ray, the joint is incongruous. So what went wrong? Let's understand the pathognomy. So disruption of the collaterals, it damages either from the base of the middle phalanx or at the head of the proximal phalanx. Then it rotates around the intact ligament and the proximal phalanx wedge between the lateral band and the extensor tendon. So that commonly prevents the close reduction at the first instant. So they usually present like a boutonniere deformity, looks like a central slip rupture, but one must do the thorough X-ray and the clinical examination, so they will present properly as a rotational or coronal injuries. So how do you test? Test the joint in full extension, right? You're testing the joint in full extension for checking the proper collaterals. So in full extension, you can check and the for the proper collaterals in 30 degree of flexion. If you see, you can checking the accessory collaterals. So it will give you idea about whether they are stable or unstable and which ligaments are torn. Okay, and preferably it should be done under digital block because patient is cooperative and you can have the good examination. So radiologically, if you do the X-ray, you may find some of the avulsion fractures and could be a joint subluxation, something like this. So if you have a complete tear of the collateral, you will have the complete dislocation. Coming to the management part, the grade 1 and grade 2 are preferably treated with the non-surgically because they are stable. If you reduce them type 2 injury, they will be stable in full flexion and full extension and can be treated very well with the taping, and just you can start the range of motion as early as when the pain and swelling is decreased. But the grade 3 tier or which are not reducing because of the some entrapment or if they are unstable after the reduction of the joint. So coming to the first case, here close reduction was attempted and could not be reduced. So what went wrong? So the treating surgeon did the ultrasound and found the avulse fragment was entrapped between the joint, which through which it was the not possible to reduce it congruously. So what is the approach? Is a mid-axial or the dorso-radial or dorso-ulnar, depending on the where site is approached. So if you mark those points at the joint, you can take a straight incision mid-axial and you can approach to the joint. So lift the lateral band. So this can be very useful for the treating the other phalanx fracture as well. So this is mid-axial, and you can put either micro anchors or the anchor which is available, and you can fix the avulse ligament. So the same case, dorsoradial approach was used, and this you can see it was avulse from the head of the proximal phalanx, and which was fixed with the suture anchor, and the full functional range was achieved at the 4 weeks. So if you see the literature, you can see multiple case reports because, as I said, these injuries are rare. They're not common as the dorsal dislocation. So lots of literature have been reviewed, and these are the isolated single case reports, and where all the close reduction were attempted and they failed because some of the entrapment. So this is one of the index case by the PC hose. The radial collateral itself entrapped into the joint and could not be reduced. Again, the same approach was used to reduce the joint and fix with the suture anchor. And the same, the case which I shown, this was again the entrapment of the osteochondral fragment in the joint, and this was approached surgically and taking out the interposed fragment and fixing with the suture anchors. So to summarize, these are uncommon injuries. Okay. So give the local anesthesia, finger block. You can assess them clinically very properly. You can have the treatment based on your examination. So whenever attempt the close reduction, they are stable. You can start them early range of motion with the taping. If not reduce, do the local ultrasound, the best non-invasive thing which you can do, and go through the mid-axial and fix with the micro anchor. You can have the good results. Thank you.
Thank you, Prashant. Really good
Yeah.
talk on a
Yeah.
uncommon topic. Kiran.
This one. So again, the approach is
Line diagram you showed now. What is entrap? The first few slides. The button holding also. The drawing which you made the drawing. Drawing.
this one.
The next one. Yeah. What is that? Point is the point.
Huh. So these are the lateral bands and the central slips. So once the dislocation happens, the collateral, the proximal phalanx goes between the central slip and one of the lateral band, and that wedges, and that sometimes prevent the close reduction. So you can give the local ring block, and you can do the close reduction there. And some of the case reports which are shown, those entrap the collaterals or the some of the small osteochondral fragments.